Thanks, Grant. Good morning, and thank you for the invitation. I'm mindful of the importance of this lecture to the college, the legacy of Dr. Cottrell, and when one sees the list of people who've had the opportunity to give this lecture before, and I see John Chalmers did this most recently, it really does epitomise the opportunity to kind of stand on the shoulders of giants in our own field, so I thank the college for this honour. I'm going to kind of maybe take a step to the right of a social epidemiology talk and really try and share with you how advances in arterial wall imaging have actually helped us understanding the fundamental approach to the way that we should be treating our patients with coronary disease. This slide summarises my disclosures. So atherosclerosis is a chronic disease. It's not a disease that suddenly starts when the patient first has their acute coronary syndrome in their mid-50s, 60s and 70s. It's a disease that slowly accumulates within the walls of the arteries throughout the body over the course of decades, and that gives us a number of opportunities along the life course of the disease to prevent, to detect, and ultimately to treat the disease. And by the time patients get into my hands as a clinical cardiologist, the sobering reality is that we're dealing with a diffuse form of atherosclerosis, which presents considerable challenges in terms of its ability to be treated. We've been looking at the ability to image the coronary arteries in particular since 1958. This is Mason-Sones, and on the right that's a picture of the very first coronary angiogram that was performed at the Cleveland Clinic. In fact, it was an accident at the time in the mid-50s while people were interested in imaging the coronary arteries and injecting substances into the arteries. There was a concern that doing so would precipitate a ventricular arrhythmia and sudden death. So in fact what you see there is a shot of the right coronary artery, which was thought to actually have been a contrast injection in the aorta. Quickly appreciated it was a coronary artery, and very quickly appreciated that the patient didn't have a ventricular arrhythmia, the patient survived, and so was born the modern era of angiography, which we use daily in our clinical practice to diagnose and quantify the extent of obstructive disease in the coronary vasculature. It helps us to triage our patients to a range of medical and revascularisation strategies. But what we've seen over the course of the last quarter of a century in particular has been profound technological advances in the ability to image the artery wall. We can do this invasively, we can do this non-invasively, we can do it in a range of vascular territories. We can now not only see where the disease is, we can start to quantify the disease, we can start to look at the individual components within the disease. And as I'll show you towards the end of this lecture, I think the next generation of imaging will really start to be able to show us the functional activity of the disease. And I think that each of these pieces of information have an important contribution in trying to help us understand the factors that drive the natural history of the disease, and can we either arrest disease progression, which is the natural history, or can we in fact promote a reversal of the disease process, which hopefully I'll show you has become the new standard in terms of the way we treat our patients. The reason why these modalities are important and why they provide incremental information above and beyond the angiogram is the angiogram actually doesn't image atherosclerotic plaque. It simply shows you the obstructive complications of the disease. It provides a two-dimensional silhouette of the lumen of the artery. We know that atherosclerosis is fundamentally a disease of the arterial wall. So if you truly want to understand the factors that influence the natural history of the disease, then you need to be looking at the wall of the artery rather than the hole in the middle. We know this because the pathologists have told us that arteries are not passive participants in the atherosclerotic disease process. This isn't simply a plumbing problem where you block off the pipes. In fact, the pipes are active players in the disease process. We know that they remodel, they change their size and their shape as atherosclerotic plaque accumulates within the wall. We have observed from pathology studies and subsequently confirmed in vivo with imaging that what in fact happens is as plaque starts to accumulate within the wall of the vessel, the artery actually expands out. And for quite some time it will do that without any change in the lumen. Given that the angiogram shows the size of the lumen, since it didn't change size, you can accumulate a lot of plaque within the artery wall without seeing any changes on an angiogram. And it's only very late in the process where the artery starts to constrict down, the lumen starts to shrink, the lumen starts to shrink, the angiogram starts to look abnormal. And so it really does reflect that the angiogram is simply showing you the tip of the iceberg in terms of the large burden of atherosclerotic plaque that our patients would clinically manifest atherosclerotic disease harbour. We know that's important in terms of clinical relevance. Here is an imaging report looking at culprit lesions of patients who present for percutaneous coronary intervention and looking at the relationship between the pattern of remodelling and the clinical presentation for the patient. And what we consistently observe in imaging studies such as this is the patient with acute ischemic unstable syndrome actually typically has a much more expansive form of remodelling. And so this kind of adage that many patients with acute coronary syndromes may have relatively minor stenoses on their angiogram doesn't mean that they have a small amount of disease. In fact, there's a large burden of disease. It's just the arteries kind of bulged out. So remodelling is important, and that becomes an important feature in terms of can we develop imaging as an approach moving forward to phenotype higher risk patients that may warrant more aggressive intervention. We've had the opportunity to use intravascular ultrasound, the ability to place a high ultrasound transducer about 2 millimetres in diameter on the tip of a catheter and place that within the coronary vasculature. And by imaging the same coronary artery at different points in time, we can actually measure the volume of plaque within an artery, and we can do that over time. We can look at the factors that influence the progression of disease, and we can use it in clinical trials to see if medical therapies can either, one, slow or halt progression of disease, or two, ultimately promote disease regression. And what we've seen over the course of doing these studies in the last 15 years is a gradual increment in the story and really the importance of lipid lowering. And what we've seen is that use of increasing intensity of statin therapy and gradually lowering LDL cholesterol levels to lower and lower levels has at first been able to slow disease progression, could then halt disease progression. But most recently, we've really seen that achieving the type of LDL cholesterol levels that we are trying to achieve in our patients with established disease, according to our treatment guidelines, really starts to associate with disease regression. Here is data from the SATIN study. It's the largest serial imaging study ever performed in the coronary vasculature, and seeing that high-dose atorvastatin, high-dose rosuvastatin treatment achieving LDL cholesterol levels of 1.8 millimoles per litre and below associates with disease regression. So it very much underpins that what we're trying to do in our patients in the clinic should associate in most of those patients with a shrinkage of the disease that's accumulated slowly over the course of decades. We've also learnt that other factors associate with the ability of statins to slow disease progression. Here you see the relationship between changes in C-reactive protein and the rate of disease progression. An early study of more intensive statin therapy, and you see that there is a clear relationship. The greater the lowering of CRP, potentially the greater anti-inflammatory effect, the greater the impact in slowing disease progression, and that was independent of the effects of LDL lowering. So these studies started to suggest and support the concept that perhaps statins were acting at the level of the vasculature by not only lipid lowering but potentially non-lipid lowering effects. And if you see in the SATIN study here, if you look at patients in terms of the degree of regression, stratified according to whether your C-reactive protein decreased or increased during the course of the trial, the concomitant inflammatory milieu did appear to associate with the relative degree of regression. So high-intensity statin therapy is important, lowering LDL cholesterol is important. It may be that inflammation, which we continue to see as an important target moving forward, may be an important factor in terms of influencing the degree of regression we observe. So when we plot the relationship between the achieved levels of LDL cholesterol and the rate of disease progression, we see, just as we've seen with the cholesterol treatment trialists and their cardiovascular outcome meta-analyses, that there's a clear linear direct relationship. The lower the LDL cholesterol, the greater the impact in slowing disease progression. It looks like getting an LDL cholesterol below 70 milligrams per decilitre or 1.8 millimoles per litre appears to be the point at which we start to see regression. And so I'm able to say to my patients that the treatment target that I'm currently aiming for in terms of guidelines for patients with established cardiovascular disease, if I can get your LDL cholesterol below there, I should be able to start to shrink your plaque. And that becomes an important kind of point in terms of trying to promote compliance with not only ongoing statin therapy, but relatively high intensity statin therapy to achieve that. We know, however, that not everybody that achieves an LDL cholesterol below 1.8 undergoes disease regression. We also know that not everybody below 1.8 is free of a subsequent cardiovascular event. And here is an analysis of factors that we looked at a number of years ago that associate with ongoing rate of disease progression, and we see ongoing progression in about 30% of patients with an LDL cholesterol below 1.8. You're more likely to progress if you have diabetes, if your systolic blood pressure increases, your HDL cholesterol level decreases, or your apolipoprotein B, a measure of your circulating LDL particle number, increases. And there are two take-home messages of that observation. First of all, it very much reinforces that atherosclerosis is a multiple risk factor-driven disease. So simply lowering LDL cholesterol is not going to be enough. If you have other risk factors, particularly if they're uncontrolled, you have an ongoing substrate for disease progression, and that's what we'll see. The other point is that apolipoprotein B tells us that LDL cholesterol does not tell us the whole story about LDL. It simply tells you how much cholesterol is within the LDL fraction of the plasma that's sent off to the lab when you order a lipid profile. It tells you nothing about the individual LDL particles, and we know from an atherosclerosis perspective that LDL particles are the ones that go into the artery wall. They're oxidized, they're taken up by macrophages to become foam cells, and so the particle's important. And here you see illustrated two patients who have the same cholesterol level, but they have two very different situations in terms of their particle load. On the left is a patient who has a small and a lesser number of particles. Each particle per particle would contain more cholesterol. On the right, an individual who has many more particles, each particle per particle containing less cholesterol, but the total still adds up to the same. And these, from an atherosclerosis perspective, are not the same patient. It's the patient on the right that continues to harbour a much greater risk of ongoing cardiovascular events, ongoing disease progression, and our observations of the relationship between ApoB and ongoing disease progression despite satisfactory levels of LDL cholesterol, I think reinforces that and tells us that there may still be scope for lowering LDL cholesterol above and beyond a statin, and that's certainly been something that we've been interested in looking at in the last few years. We've seen the development of a whole new class of lipid-lowering agents, monoclonal antibodies that are targeted against PCSK9. We know that PCSK9 is an important factor in regulating the expression of the LDL receptor on the hepatocyte surface. What should happen is circulating LDL particles in their cholesterol interact with the LDL receptor. The whole complex is internalized within the hepatocyte. Within the hepatocyte, the receptor dissociates from the particle and its cholesterol is dealt with, and the receptor should recirculate to the cell surface so it can continue to remove excess LDL particles from the circulation. PCSK9 blocks that process. We know that gain-of-function mutations of PCSK9 have now been identified as the third cause of autosomal dominant familial hypercholesterolemia. We know there are a range of polymorphisms associated with less PCSK9 activity, which not only associate with lower levels of LDL cholesterol, but also in large cohort studies, a lower risk of cardiovascular events. And so it really became quite intuitive that the development of inhibitory approaches to PCSK9 would be the next big thing above and beyond statin therapy. And that would provide an opportunity not only as an alternative approach to lipid lowering for patients who may not be able to achieve conventional goals with current therapy, or potentially in the setting of statin intolerance, but it may also open a new frontier of being able to lower LDL cholesterol to much lower levels. We now have the capacity with therapeutics to be able to lower LDL cholesterol down to 0.6 millimoles per litre, down to the types of levels that we're born with, and really should never have kind of increased over the course of our life. We have performed a serial imaging study where we've taken patients on a stable dose of statin therapy. So these patients who were all very well treated, 2/3 of which were treated with high-intensity statin therapy, all patients with clinically manifest coronary disease, and treated them for 18 months with either placebo or the PCSK9 inhibitor evolocumab in addition to their statin therapy. You see the difference in LDL cholesterol levels in the two groups, 2.3 and 0.9 millimoles per litre. That becomes the lowest LDL cholesterol that we've seen in a very large cardiovascular trial of any form. And you see that the ability to lower LDL cholesterol in that setting below 1 millimole per litre associates with incremental disease regression above and beyond what we have seen in the patients treated with a statin, suggesting that even lower may be better. And to reinforce that, here is a low-S plot looking at the relationship between achieved levels of LDL cholesterol and the rate of disease progression. And really, again, what we continue to see is the linearity of that response. What we had wondered when we did this study was, would we observe a change in the slope of that relationship at some point? Would you get to an LDL cholesterol level whereby you no longer saw an incremental benefit, and down to a level of 20 milligrams per decilitre or 0.5 millimoles per litre, we saw no loss of increasing benefit, really suggesting that there is a linear response all the way down to at least that level. Again, increasing ability to lower LDL cholesterol levels to lower and lower levels results in a greater ability to regress or reverse the disease within the coronary vasculature. We know that other lipid parameters may be important in terms of their impact in disease progression. We've seen modest increases in HDL cholesterol in the statin trials in the range of 5 to 20%. Here is a pooled analysis of patients who were new to statin therapy, 1,500 of them, and looking at what the lipid predictors of the ability of a statin to slow disease progression. Not surprisingly, lowering LDL cholesterol was an important predictor, but just as important was the ability to modestly raise HDL cholesterol. And in fact, it was the patient who not only was really able to get their LDL cholesterol low, but was able to raise their HDL cholesterol on a statin who actually appeared to demonstrate the greater degree of disease regression. And it's observations such as this which continue to excite many of us that there may be an HDL target that may be of benefit in terms of clinical trials. We've seen a number of failures in that space in the last few years, yet it's observations such as this that suggest that targeting HDL in one way or another, and it doesn't have to necessarily be particularly profound increases, may have an influence on the natural history of the disease. We've seen a number of programs look at simply infusing HDL, not looking for quantitative changes in HDL, but simply looking to qualitatively deliver a functional form of HDL, promote lipid mobilisation, and we've seen now in a number of studies performed over the course of nearly 15 years, reductions in atheroma burden, perhaps less so in the modern era, and whether that has implications for whether targeting HDL may be less relevant in the modern era of aggressively treating patients with high-intensity statin therapy remains to be determined. Yet, being said, there continues to be interest in whether we can develop one of those therapeutics and ultimately bring it to a clinical trial to evaluate their effects on cardiovascular events. There is an increasing, and one would perhaps say a resurgence of interest in the role of triglyceride-rich lipoproteins. The cardiovascular field has been challenged for years. Is it HDL? Is it triglycerides? The disappointing results of the HDL raising trials, the disappointing results of the HDL genetics perhaps has dampened enthusiasm in that space. In contrast, there's very good genetic data suggesting that triglyceride-rich lipoproteins are likely to play a causal role in the atherosclerotic disease process. Here you see the impact of having lower and higher levels of both non-HDL cholesterol and triglyceride on disease progression in patients who achieve an LDL cholesterol above and below 1.8 millimoles per litre, really just focusing on the patients who appear to be at acceptable goals with an LDL less than 1.8. The presence of a higher level of non-HDL cholesterol and triglyceride do appear to associate with more disease progression, again suggesting that there may be a benefit by targeting those factors above and beyond statin therapy moving forward. We know that diabetes has been a considerable challenge in terms of our management of coronary disease. We know that it's a particularly malignant and aggressive form of disease progression. But again, we have seen an evolution in our observations of the effect of therapeutics in this space. Our initial observations from an imaging perspective were that in diabetes, if you lowered LDL cholesterol, you could slow disease progression, but you couldn't arrest disease progression. You did not see the same magnitude of effect that you saw in the patient without diabetes. Now, you did see a benefit, and that's very consistent with the clinical outcome trials that show that statin therapy consistently reduced events in the diabetes subgroups, but it did suggest that there were other factors that were likely to be continuing to promote disease progression, and that we needed to look to see how we could more intensively treat these individuals. What we have seen in the modern era, using both high-intensity statin therapy and PCSK9 inhibitors, in fact, that you can promote disease regression in the patients with diabetes. And so I think, again, it really just reinforces the concept that the higher risk individuals are those who are most likely to achieve a greater benefit. You've really got to aggressively treat them. So again, high-intensity lipid-lowering therapy can promote disease regression in diabetes. But it turns out that neither LDL nor glucose are actually the most important factors that drive the actual progression of disease. Once you've got clinically manifest coronary disease in the setting of type 2 diabetes, the most important factor is the ratio of triglyceride to HDL cholesterol, and it really reflects the fact that that atherogenic dyslipidemic state, which is very common in the setting of insulin resistance and type 2 diabetes, is really critically important in terms of promoting ongoing disease progression, and really reflects what should continue to be an important target, not only for the therapeutics that we have in clinical practice today, in particular fibrates, but in terms of the way that we develop therapeutics moving forward. Ultimately, we know that type 2 diabetes is really a multiple risk factor metabolic syndrome, and so again, the most important observation really is the ability to treat these patients globally. Here is an analysis that we undertook in 2012, which really tried to look at the STENO2 approach to, could we identify a multitude of risk factors? Could we identify multiple relatively aggressive treatment goals, and then look at what disease progression looks like as you achieve more and more of them? And as you can see, increasing number of targets of more aggressive risk factor attainment is associated with a gradual slowing of disease progression. In fact, if you're able to achieve all of those tight targets, and some of them are perhaps less tight in 2012 than what we'd consider them to be in 2017, that you can actually promote disease regression. Again, reinforcing the multiple risk factor nature of the disease that we're dealing with, particularly in the setting of the highest risk patients. Now, if you kind of looked at a lot of the axes for what I've kind of presented there, it looks like there's a 1% reduction in plaque, and you'll sit there and think, geez, that seems like a lot of effort to reduce the size of a plaque by 1%. But things are not necessarily always what they appear to be, and if you kind of think about it, we start with a percent atheroma volume of about 40%, suggesting that what we're measuring is about 40% of the total volume of the vessel wall, keeping in mind that the lumen is going to take up a fairly significant chunk of that. If you take that parameter, probably about 2/3 of what we're looking at is probably normal vessel wall, and of that 1/3 that remains, probably about 50% of which is probably non-modifiable material, calcium, fibrous tissue, factors which you simply are not going to be able to remove from the artery wall. They're also not actually going to cause any cardiovascular events. We know ultimately that it's a inflamed, lipid-rich necrotic plaque that's going to cause an event. It's not the fibrosed calcific one. And so if you kind of distill it down to those numbers, in fact, an absolute reduction of 1% is probably only coming out of something like 8%, suggesting that in a relatively short time period of 18 months, in the life course of the disease that has accumulated over the course of decades, we're probably seeing more than a 10% reduction in the modifiable pool. So suggesting that we can modify the disease, also suggesting that there's still work to be done continuing to treatment patients beyond that point in time. And so therefore it's not that surprising that what we see on imaging does actually correlate with cardiovascular events. We've seen that there is a clear relationship between disease burden and outcome. The pathologists reported it from autopsy studies. We've seen those reports from the coronary angiography series, carotid IMT. Here you see our experience with intravascular ultrasound. The more plaque you have, the more likely you'll die, have a myocardial infarction, or require coronary revascularization. Similarly, if you stratify patients according to baseline quartiles of disease, the more you progress over time, the more likely that you'll have a cardiovascular event. And what we see time and time again, and we've been able to update this slide, given that we now have clinical outcome data supporting the benefits of PCSK9 inhibitor, we consistently see where a therapy has a favourable effect on disease progression. In parallel studies, we see very similar benefits in terms of their effects on clinical outcomes. You see the results of the Glagov trial, which I've already shared with you on the left, and the recently reported results of the Fourier study on the right, where evolocumab, in addition to statin therapy, achieved a 15% reduction in the primary composite cardiovascular endpoint, in fact a 20% reduction in the hard triple endpoint of cardiovascular death, myocardial infarction and stroke. So that all sounds good. That shows you about the burden of disease. But as I said, I think we now appreciate, and the pathologists have shared with us, that there's much more to atherosclerosis and its link to disease than simply how much plaque there is. We know that the phenotype of plaque is very important, and so there's enormous efforts to be able to develop imaging modalities that reliably are able to distinguish the individual components of plaque, and then what would that tell us about the disease, and what would that tell us about the effects of medical therapies. You see here the so-called virtual histology approach. It takes the ultrasound backscatter signal that we receive and generate a radio frequency algorithm that can distinguish fibrotic, fibrofatty, necrotic and calcific components. It can phenotype plaques. We can identify the so-called thin cap fibroatheroma. And you can see here in a seminal report from the Prospect investigators, you see the 3 imaging predictors of the likelihood of having a major adverse cardiovascular event over the next 3 years were not only minimum lumen area, which is a measure of plaque burden, overall plaque burden, but also the presence of a thin cap fibroatheroma, and the presence of additive of each of those parameters together actually associated with a greater likelihood of cardiovascular events over the course of the next 3 years. So we think the imaging's starting to show us the factors that are important. Here is our experience from the statin trial, looking at what high-intensity statin therapy and regression seems to do in terms of changes in plaque phenotype, and the most important change we see is actually a large increase in plaque calcification. So not only do you shrink the plaques, but the plaques that remain are much more calcified. They're going to be much more stable and much less likely to cause a cardiovascular event. We are particularly interested in the necrotic core and looking at what are the factors that associate with expansion of the necrotic core, even in the setting of statin treatment. We think that's an important piece of information to know in terms of trying to understand what are predictors of ongoing risk and what should be the new targets for therapies above and beyond statin therapy. The 2 factors that associate with expansion of the necrotic core are a low level of HDL cholesterol and a high level of C-reactive protein. And again, it reinforces where much of the interest and activity in the development of new cardiovascular therapeutics is going in trying to target those spaces. It's very consistent with what the biology is telling us. We're now able to use a number of other imaging modalities which give us complementary information in terms of atherosclerotic disease. We can use optical coherence tomography, the ability to use light rather than sound within the coronary vasculature. As you can see on the left, that gives exquisitely high resolution imaging, the physics of which is that you typically gain with something, you lose with something else. The trade-off is typically the penetration. But what it does is it gives you very high resolution imaging of the superficial elements of the plaque. So we can see the lipid pools below the surface. We can see microchannels, which we believe are those kind of new vessels that form within an unstable vulnerable plaque, and we can start to measure the fibrous cap thickness. And that becomes important in the first instance in terms of observational studies, and then ultimately the next generation will be to perform serial studies to look at the effects of therapeutics. You can see here in our experience at the Cleveland Clinic, just simply from an observational perspective, patients with higher levels of LDL cholesterol are much more likely to have lipid plaques in their lesions. The extent of lipid in terms of the arc that we're able to measure is greater, and not surprisingly, the thickness of the fibrous cap is less. So again, OCT starts to show us a relationship between lipid levels and the likelihood of plaque instability. We can measure cholesterol crystals using this technique. We know that cholesterol is not only important from the perspective of an LDL particle going in, being taken up by a macrophage to become a foam cell, but in fact free cholesterol within the atherosclerotic plaque itself can crystallise in a very similar notion to the way that uric acid can crystallise in gout. And why this is important is that cholesterol crystals have now been identified as a potent inflammasome activator. And so the ability for cholesterol to crystallise within the artery wall is going to be a major driver of the inflammation that we know is important in terms of the natural history of disease progression. We can see cholesterol crystals on optical coherence tomography, and we know that the presence of a crystal is associated with a thinner fibrous cap, more microchannels, those new vessels, and a greater likelihood that we'll see evidence of plaque rupture. So again, linking cholesterol to the biology and ultimately to the instability of the disease. We see from an observational perspective that the use of more intensive statin therapy is associated with thicker fibrous caps, more likely to see microchannels. Again, this is all observational. The next step will now be to try and perform the serial studies that we've performed previously with intravascular ultrasound, but to start to look at the effects of new therapies on plaque phenotype. We've used near-infrared spectroscopy, the ability to measure the amount of lipid within an atherosclerotic plaque. You see patients treated with a statin in orange are likely to have less lipid within their plaque, so we can start to use this in terms of quantifying changes with new therapeutics. We know that calcium is an important factor in terms of how it influences the natural history of disease. We know that calcium scoring predicts a patient who's more likely to have an event, yet it is not where the calcium lies in which the event will occur, because that large chunk of calcium is a plaque that is extremely stable and will not rupture. In fact, here it really looks at the likelihood of any change according to the degree of calcification, and looking in our studies, patients with lesions that are more calcified, in fact, are less likely to both regress or progress. The biological substrate for progression, the biological substrate as the target for intervention, just is less likely to be modified in heavily calcified lesions. That being said, we've now identified that there are different patterns of calcium. In fact, there are more spotty microcalcific patterns of disease which we think are associated with the inflammation associated with plaque instability. And you can see here that the presence of spotty calcification anywhere within a coronary artery is associated with a much more progressive form of disease throughout the length of the vessel, suggesting again the ability to be able to detect phenotypes of the disease that are associated with more disease progression. We can see spotty calcification in optical coherence tomography, again, very consistent with the prior observations. Where there's spotty calcification, where we think there's more inflammatory disease, the fibrous caps are thinner and there's more likely to be evidence of plaque rupture. So when we put all of that together, we can actually start to identify a broader phenotype of what we think a high-risk plaque is. And a high-risk plaque is one that's going to be more progressive. The question would be, would that be more susceptible to therapeutic modification? And it appears to be that if you have disease where there's evidence of not only high plaque burden, but also spotty calcification and that expansive remodelling of the artery wall, in orange, in the untreated setting, that represents a patient with a greatly accelerated form of disease progression, much greater than we've seen typically in most of our studies and most of the subgroups that we've looked at. Yet in green, if you take those same patients and you treat them, they regress. And it really reinforces the concept of trying to understand and identify the modifiable biological substrate of disease, and we certainly think that now imaging has the potential to do that. We've made all of these observations from a non-invasive perspective, but now we have the opportunity with the evolution of non-invasive techniques, particularly CT, to really kind of take those steps forward in terms of the clinic. The change in the story becomes that not all plaques that cause an acute ischemic event rupture. And in fact, there's been an evolving story by the pathologists that many of these plaques may erode, and it's really the analogy that if plaque rupture is like smashing an egg on the road, eroding a plaque's like skinning your knee. But they can both have exactly the same sequelae. They can both expose circulating blood and thrombogenic circulating blood to components of the artery wall that they're not normally exposed to, and stimulate thrombus and lumen occlusion. We know that the pathology is potentially different. We are now able to identify plaque erosion using imaging, particularly with OCT, and why that is relevant is that in the setting of acute coronary syndromes, the culprit lesion appears to be plaque erosion rather than rupture in probably close to 1 in 3 settings. So this may have important implications in terms of our ability to diagnose, prevent and treat the disease, and really is a field that's kind of rapidly evolving in trying to understand how that is different than the conventional story that we've been treating for many years. Why that may also be particularly important is that there is a clear gender difference. The pathologists have identified it, and we've now seen it with imaging. In both the stable and the unstable setting, we are much more likely to observe plaque erosion in women compared with men. It may reflect another difference in terms of the natural history of the disease and its association with gender, and certainly is an area that many of us are trying to understand to a greater degree. As I said, can we ultimately translate these modalities to non-invasive techniques? The resolution is better, the cost will come down. There is a proliferation in particular of coronary CT angiography, which I think has perhaps the horse bolted before the barn door closed, and there was any evidence to prove that. That being said, there is a great opportunity for us to try and harness that potential and try and understand how we can use it in our clinics effectively. We need appropriate clinical trials that will help inform us on the best way to efficiently and cost effectively use this for our patients, both in terms of predicting risk and monitoring their response to treatment. The next wave will ultimately be that of molecular imaging. Can we use radioisotopes that target specific factors in the natural history of transitioning a stable to an unstable plaque? Can we combine that with anatomical imaging to localise the plaque, and then use PET imaging to actually image the functional activity of plaque? And while there's been a lot of activity with FDG as a relatively crude measure of plaque inflammatory activity, I think where many of us are more excited are the recent reports that sodium fluoride appears to detect vulnerable and not vulnerable plaques. And why that may be important is because I think it's highly likely that the sodium fluoride is going to again reflect that microcalcification and that more inflammatory form of disease that I kind of reflected on in our observations from both intravascular ultrasound and optical coherence tomography. Ultimately, what we really want to do with imaging is not only see how much plaque there is, the composition and the function, but ask the question, can we translate this from something that helps us understand the biology and something that helps us develop new drugs to something that we can use in our clinic? Can we use it to predict risk? Can we use it to evaluate therapies and monitor therapeutic responses in our patients? Will it change clinical practice? Will it improve clinical outcome? Unfortunately, in the cardiovascular space, there have been no legitimate clinical trials that have asked these questions. They are sorely needed. We have some evidence that having abnormalities on imaging does influence management. Here is data from the MESA study suggesting that having a high calcium score meant that your physician was more likely to initiate risk-reducing therapies. If you were on those therapies, you were more likely to continue them. So it does appear to have some behavioural change, although that's observational. We are undertaking a clinical trial in association with Tom Marwick and his colleagues at the at the Baker Research Institute. This is an NHMRC-funded study called CORT-CAD, where we're taking individuals with a family history of coronary disease who don't qualify for statin, performing calcium scoring to see whether that will triage patients to a statin and whether that will have an impact on disease progression. It's not looking at cardiovascular events, but at least it's a step forward in terms of trying to ask the question. So really, to kind of put all that together, we have to move our story beyond residual risk. We have to talk about modifiable risk. It's ultimately, can we identify the patients who have the disease where there is a benefit to be gained by continuing to target? We know that there will be factors that can drive ongoing events that cannot be modified: age, gender, family history. What we want to be able to do is identify the patients with the more modifiable disease, and we really are at the forefront of being able to develop imaging from that perspective, and I think that is what is sorely needed. So on that note, I'll thank you for your attention and thank you for the opportunity.